Hello, everyone, and welcome back to your live Facebook for Monday, May 3rd. If you can believe it's already May, I know that I certainly cannot. But we are all continuing along in positivity as we move forward in our journeys, wherever that journey may be for you. I apologize. I'm just like getting things kind of set up here. I had some technical difficulties to start out with. So we'll just give some time for folks to join. And tonight, I'm just hoping to do mostly question and answer time, because I know that that's a lot of the questions that folks have. And I just want to make sure that we, at least maybe once a month, we dedicate just a whole evening to answering your questions. Because I've noticed as the weeks have gone by that there are a lot of times a lot of questions that don't get answered. And so I just want to make sure that tonight I do the best job that I can answering questions. So what I'm probably going to do is just kind of, I have some frequently asked questions that a lot of our clients do ask. So I'll have those kind of keyed up in case people don't have questions, or my luck, the one night I want to answer questions, the questions will be slow. But before I do that, I just want to say good evening, Vanessa and Anne, Amber, Diana, Callie, Jeanette, Jenny, everyone. Thank you so much for joining me. It's such a fun time to have the privilege of answering your questions and doing these live Facebook feeds every Monday night, because I know that you all have very important things to do with your time, and our time is certainly spread thin as we're involved in this process. I was speaking with a client last week at some point, and she and I were just discussing that, your life goes on during this process. Your whole life continues to go on, your job, any other responsibilities that you have. And then we're just expected to sort of fit in all these appointments and all of these medications. And there's a lot of information. And so just be patient with yourself as we go along. If you have questions, make sure you ask them. One of the best things that you can do to kind of set yourself up for success is to be organized. And we talk a lot about that in terms of just having a folder and having all of your prescription paperwork from the pharmacy. I know that we don't all have access to a printer in this day and age, but just being able to print out your written instructions and sort of reference those as you go along the process really helps to make sure that you don't get tripped up by something basic. And so it's just, it's definitely a good thing to be as prepared as you can be, have everything kind of laid out. That way, as you go, as stresses pop up, because we know that things are going to pop up that we did not expect. And so how well we handle those things as they come at us oftentimes is a determining, not necessarily the determining factor, but can play a role in our outcome. So, okay, so let me go. I'm just going to start at the top here and start answering some of your questions. Sarah Beth says she just got her travel packet filled out and can't wait to start. Sarah Beth, thank you so much for being on top of that. It seems pretty basic, but like I mentioned before, a lot of us have so many other responsibilities that we also have that sometimes we can put off things. I know I'm a procrastinator. So the more I have to do, the more I get done. But it is important that travel packet, make sure you've read it cover to cover and that you've filled it out and returned it. That will prevent a lot of last minute things from popping up. It will also help you to be best poised to understand what the process is as we go through. So Natalie is asking, how does CNY do an egg retrieval? So that process is done most often under anesthesia. It's called monitored anesthesia care. So we keep you extremely comfortable. You won't know what's going on, but you won't be so anesthetized that you're unable to maintain your own airway. So the anesthesia for the egg retrieval is just enough to make sure that you're not really aware of what's going on. The retrieval itself is done just like the transvaginal ultrasounds that you do at your monitoring visit. So your monitoring visits each visit is going to involve a transvaginal ultrasound. It sounds pretty rough. It's not horrible, but it does take some getting used to. But a probe is placed in the vagina to more accurately assess what's going on in the ovaries and the uterus. And so that same ultrasound probe if you had a transvaginal ultrasound, it's that same exact ultrasound probe that's used, but we place a needle guide onto the probe itself. And then our ultrasound machine has a guide to show exactly the line, the path of the needle. And so the doctor is able to visualize the ovaries and line that ultrasound probe with that needle guide up. He's trying to target, and will advance that needle forward and insert it into the follicle itself, and then apply some gentle suction to aspirate or withdraw the contents of that follicle from the follicle itself. And with that is fluid, follicular fluid, and the egg itself comes out as each follicle is aspirated. So that's kind of how an egg retrieval is done. I certainly do hope that answered your question, but if you have follow-up questions, certainly ask. Nicole's just saying she had ERA and endometrial receptivity testing done today. Yep, 2 weeks is about the good standard time, at least for the ERA testing. Samantha is asking, does CNY allow you to move forward if your A1C is elevated? So Samantha, one thing I would say, the most important thing that I would say is that it is your body, your money, and your time. And so we will always tell you what we think is best for you medically. But with that said, you are able, typically, unless it presents a risk, a health risk to you, you're typically going to be allowed to proceed, even if the guidelines are not the guidelines, but the recommendations to not proceed. So let's delve deeper into that. Why do we care? Why would it be a problem if your A1C is elevated? So a hemoglobin A1C is a lab value that takes a look at your average estimated glucose over the last 3 months. A red blood cell is about 3 months. And so an A1C evaluates what your blood glucose average has been over the past 3 months. We also know that the life cycle of oocytes is about 3 months in terms of what you do today affects your oocyte or your egg health 3 months down the line. So an elevated glucose level is going to be indicative usually of some insulin resistance, which means the pancreas is offloading insulin into the system to control that glucose, but that estimated average glucose is still high, which is telling us that your body is being resistant to the insulin. The more insulin we dump out, the more your blood sugar should be controlled. However, there's multiple different reasons. Diabetes is one of them. Polycystic ovarian syndrome is one of them. But there are situations in which the body is not as receptive, or it doesn't respond the way it should to insulin. That's called insulin resistance. And we know that the ovaries don't function at their peak in a situation where there's insulin resistance. And so what oftentimes would happen is if your A1C is elevated, that's just going to tell us that we're going to have a harder time stimulating the ovaries, and we're going to get less quality eggs out of them. And so while, yes, you would be allowed to move forward, medically, it would be a lot probably more advantageous for you to start keto. Kiltz is keto. Definitely look at cnyfertility.com for a lot of good resources on how to pursue Kiltz's keto, Dr. Kiltz's way of doing keto. It's very different, but it's extremely effective. And doing a ketogenic diet can absolutely help bring that A1C level down. And so you could absolutely start a cycle, but at what outcome and at what cost? So if you do a cycle now with your A1C elevated, you may get half the eggs that you would get if you took the 3 months, properly prepared your body, and then went through that cycle. And so it's just it's a time benefit analysis. It's a cost benefit analysis. We certainly understand that the majority of you watching tonight have wanted to be pregnant a very long time before you made it to our doors. And so we understand that desire to move forward as quickly as possible. With that said, though, sometimes we miss the forest through the trees. We end up spending more time attempting to get pregnant trying to rush because we didn't put our bodies into the best state that we possibly could before we started. Next question, Vanessa says, would you be able to give me your opinion on a 5AB embryo sticking versus a 4cc? This is really a much better question suited for our embryology team, but I will do my best. I would say that, certainly if those embryos are untested, meaning we did not do any genetic testing on them, then statistically, the 5AB certainly does have a better chance of sticking versus a 4cc. But what I would offer is that it's not uncommon that if we know that genetic testing, which is called PGTA, it used to be called PGS. We know that is certainly not the end all be all in terms of an embryo's outcome to live birth. Okay. With that said, there is some strong research to suggest that once an embryo is genetically normal, then the grading, and that's the 5AB, the 4cc, that grading is of really very little of any consequence. And so I'll give you a personal example in that I had my son through IVF, and he was what the embryologist called an ugly embryo, or not necessarily ugly, but just so you know, this one doesn't look the best. And so my son was actually the poorest of all of the embryos that I had. And so I just point that out to say that while yes, it is research that a higher quality or a higher graded embryo may have a higher chance of implantation, definitely don't count out any embryos that may not have scored the highest during the beauty contest, because certainly those embryos make beautiful babies. So I'm going to Albany for transfer baseline. Will I need my transfer meds with me? Yes. So if we clear you to start your meds baseline, you will likely need those medications to start that day. Would it be the end of the world if you started the following day? Probably not. But I would say it's probably best to have those medications with you. Amy, your transfer is tomorrow. I'm so happy to hear that. I hope it goes perfectly for you. Beverly asks, so I'm scheduled for a retrieval on Wednesday. Why don't I have to take a Cetrotide tomorrow? So Beverly, if you're scheduled for your retrieval on Wednesday, then you're triggering tonight. And once we trigger, we don't want to suppress the body's natural or the body's response to the trigger. So the response to the trigger, once you take that HCG trigger or whatever your trigger shot is, you won't ovulate for 35 hours at a minimum. And that's why your trigger is married to your retrieval in terms of your trigger time is 35 hours prior to your retrieval. And so the reason why you don't take Cetrotide is because once you trigger, we want the body to undergo its natural process to begin to ovulate. We're just going to get to the party and get those eggs out before they would ovulate on their own. So I hope that answers your question. Let's see here. Callie is asking, what is the lowest number for a viable pregnancy on the first beta while also on HCG boosters? That is an extremely difficult question to answer, because we do see, differing HCG levels. I have seen very low first betas that turn out to be beautiful, healthy babies. And so I would say that first number is not as important as what it does on the second draw. And so if you did your first draw today, I know that doesn't give you much peace, but what I would say is what's more important than the number itself is the rise. Does it have the appropriate rise in a 48-hour time frame, which we look for? A lot of clients get very nervous that it's not doubling every 48 hours. But what we do consider an appropriate rise is just a 66% increase every 48 hours. So I would say, while I'm sure if your first level was a little on the low side, you're probably quite nervous, what really will tell us how things are looking is if that number rises appropriately. So I apologize, I'm not able to offer you anything more definite. I know that the waiting is the hardest part, but let's see where you're at on your first check. Rebecca is asking a wonderful question, one that I get constantly, and that is, I only have 2 large follicles on day 5. Extra prayers for better results on Wednesday. I am assuming, Rebecca, that you're referring to stimulation day 5, and I would say that that is 100% normal and expected. We know if you're on stim day 5, by the time we get your monitoring results, you've only had 4 nights of medication. So that is extremely expected. Okay, so try not to worry too much, even though I know that's much easier said than done. Another Rebecca is asking, consult on June 14th. How quickly do things go? Second IVF, first was successful, but ended in a miscarriage. I'm so sorry. Age 40, AMH 2.57. Well, I would say congratulations. AMH still looks very, very good. You are typically going to receive an orientation phone call from my team, the global travel team, about 2 to 3 weeks from your consultation. We know that's a long time. We are doing our best to get through those consultations just as quickly as we can, with the exception of clients that come to us who have cancer diagnoses and require quick egg preservation. We call our consults in the order in which they were received. And so just like you wouldn't want a bunch of people skipping the line, we just call in the order they were received. So you're going to receive a call 2 to 3 weeks from your consultation. And then typically, as long as you're able to get your medications quickly, you would be able to start the process with your cycle day 1 that's after that orientation call. And I will add, I mentioned it earlier, but I will add, I really cannot under stress the importance of taking our time. I know, like I said, I know everybody wants to get started as quick as is humanly possible, but it tends to be that the faster we rush through things, the more issues that kind of tend to crop up during the cycle. And so as I said, I certainly do know that that is easier said than done. But for what it's worth, that extra month, especially if it means a positive versus a negative, is definitely worth it. So let's see here. Faith, I am not entirely sure what you're asking. It suggested my egg retrieval today and turned out into cysts. What causes that? Why they didn't know during ultrasound. During ultrasound, a cyst can be very similar in in sonographic appearance to a follicle. So sometimes things are reported as follicles and they can be cysts. Typically, a follicle or whatever it is that grows in a stepwise fashion as we monitor is typically a follicle with an egg inside, but the real proof is always into a retrieval. So you're welcome to ask a follow-up question if I totally misunderstood. Mimi is asking, do you do egg retrievals and transfers on Saturdays and Sundays? And that's a fantastic question. So we do egg retrievals on Saturday if it is warranted. So if you are ready to trigger on Thursday, we will do your retrieval on a Saturday. Fresh transfers are done on Saturdays. However, frozen transfers are not. So just because we do have limited space, if we fill our Saturdays with frozen transfers, then those clients for whom day 3 or day 5 falls on a Saturday, they're not going to have space for their fresh transfer. So that's kind of the rationale behind just doing fresh transfers on Saturdays. And then we do not do retrievals or transfers on Sunday, as we are currently not open on Sundays. Okay. Jenny asks a question, how soon prior to my egg retrieval? I think she means, do I need to have sperm sent from the bank? I'm looking to do my first egg retrieval in July. Also, my labs were done last year in June and life got in the way. Well, that definitely happens. Do you have to redo the labs? No. Depending on what the labs were, if they were all pretty normal, probably not necessary to do them again. It has been a year, so things that could have value to repeat would be things like your CBC, CMP. Just make sure from a general health perspective, things look good. Your AMH might be a good level to look at. You didn't mention your age, but our AMHs do decrease as we age. So just in the event that yours did drop drastically, drastically or increase drastically, which you can do depending on what type of supplements and lifestyle changes you make, it might be worth doing at least an AMH, a CBC, a CMP, and maybe an A1C again. Other things would be up to you. Certainly, we're not going to require you to repeat any of those things. As far as the sperm goes, we highly recommend that you have that sperm in our office by the time you call with cycle day 1. Policy dictates we try not to start anybody on a stimulation cycle if the sperm's not in the office. Obviously, if it's been shipped or something like that, that's a different story. But as a general rule, I would say, Jenny, try to have that sperm in our office no later than your cycle day 1, the month you want to get started. Heidi, that's such a great question. Heidi asks, what's the average amount of eggs that get retrieved? There is no average number because we at CNY Fertility, we don't have, and I actually got this question today about, well, what are the statistics of getting pregnant with this transfer? And I'd like to point out that we don't turn anyone away for age, weight, AMH, previous number of failed cycles. So all of those things combined make it that it's almost unfair for us to offer you a statistic because each individual couple have different statistics. So if I'm a single woman doing donor sperm IVF and I do a round this month and then I do a round next month with another donor, the statistics are going to be different because it's different genetic material. And with that in mind, the average amount of eggs that are retrieved during a cycle varies drastically from person to person. And so with that, I would encourage you not to, as well as you can, not to compare yourself and your outcome to anyone else, because we are our own individuals in that sense that the number of eggs that I might get, or if you compare other women at the exact same age as you, medical history, lifestyle choices, nutrition, there's a lot of different factors that go into that. And so I think it's more important to evaluate how many eggs you have or what your AMH level is compared with what your baseline ultrasound shows in terms of what we call antral follicle count, and then building upon that, just because there really is no average in terms of eggs that are retrieved. Let's see here. Lindsay, do you guys not do Instagram Live? Was waiting on Instagram and nothing was happening. I apologize. I have our broadcast studio does not allow us to stream to Instagram. And I believe Dr. Kilt still does. But I find myself really distracted by looking into different cameras. I feel like I'm never looking at the right camera for whoever's question it is. So I just broadcast on Facebook and YouTube. So hopefully, those of you who are looking for me can find me here. All right. Hi, Grace. Happy Monday night. All right. So Angie, this is a fantastic question. Can you tell me about monitoring? What days does one monitor? Coming from California, anticipated period is May 24th, and my flight arrives on the 29th. So Angie, it sounds like you are planning to do all of your monitoring here in one of our offices if you're coming out here that early. So I would say to plan on your baseline somewhere between cycle days 2 and 4. And then usually we monitor you starting around day 5, 6, and then every other day until the retrieval. And that's pretty much still the same situation. If you're doing all of your monitoring at home, you would have baseline ultrasound and lab work around cycle days 2, 3, or 4. Then we typically will send you back for remote monitoring, usually days 5, 7, and 9 of meds, or days 6, 8, and 10. And the difference is it just has to kind of do with what day of the week you start and what day those days fall on. We just make sure that we monitor you early and often to make sure that we're anticipating when your retrieval is going to be. Let's see here. With a first beta of 14 today, what are my chances of having a successful pregnancy? Amber, I will tell you the same thing I said before, which is the first number isn't necessarily as indicative of outcome as is, does that double or does that rise appropriately, which is 66% every 48 hours. That's really more of the determining factor. While 14 is what we would call low positive, I have seen plenty of low positives result in pregnancies and healthy deliveries. So truly, let's hope for that number to rise appropriately every 48 hours, which will really be kind of the determining factor in terms of a successful pregnancy. All right. Anne is asking, I'm hoping to do my retrieval and fresh transfer this month. I'll be traveling to Colorado Springs office, and I'm wondering if doing a fresh transfer, do I have to stay in Colorado until transfer, or can I go home? If wherever you live, it's feasible and you would like to go home between retrieval and transfer, you 100% can do that. So as long as you're here at your retrieval check-in time and you're here at your transfer check-in time, what you do in between is entirely up to you. And if you do live close enough, I mean, I'm aware of like some of our clients that live in Pennsylvania or live in New York, but too far to drive back and forth for visits. Many of them do go home in the meantime. So that's certainly feasible. Let's see what else we have. And Anna is asking, is Albany location fully equipped? I heard several negative experiences from egg retrieval. Anna, yes, our Albany location is 100% fully functioning IVF and FET lab. And, you know, what I would say is there's always kind of two sides to every story. I would be interested to know what the negative outcome that came. I think it's very important to remember that there are just a multitude of factors that determine one's outcome. Everything down to what was the quality of the outside monitoring. We've had situations where, you know, outside monitoring results indicate one thing, and then we get you to retrieval, or we monitor you in our office and we see something different. And while that doesn't happen very often, I would say our Albany office is absolutely phenomenal. You will be taken wonderful care of by our two doctors, Dr. Grossman, Dr. Ditkoff, our nurse practitioner, Rebecca, our nurse manager, Justine, and all of our wonderful nurses and medical assistants in Albany will take phenomenal care of you. So I would say there's nothing to worry about there. Morgan, I have absolutely no idea when Atlanta will start doing transfers. As far as I know, that is not something that's imminent, meaning I don't believe that's coming anytime maybe in 2021, but things do change quickly, so definitely check back on that. Mimi is asking, do I need to have blood work monitoring and ultrasounds during my priming month? Not necessarily. Most people choose to start their priming with the beginning of their menstrual cycle the month before. And then at the end of that priming month with that period, they typically go for monitoring. With that said, you certainly could just to have more data, but we understand that monitoring visits are typically quite expensive. And so however you choose to do that is fine, but we certainly do not require that testing to be done prior to a priming month. Let's see here. Kaylee, how does it work if my husband needs a PESA test of the day of my retrieval? Yep, it's local anesthesia that's used for PESAs and TESAs. For those of you who aren't familiar with that process is, it's used for a extraction of sperm directly from the testicles or different parts of the male anatomy. So in the cases of vasectomies, there are some times where men are born without the tubes that are needed to transport the sperm from the testicles outside the body. So there's a multitude of different reasons that PESAs and TESAs are ordered, but those are done under local anesthesia. So I hope that helps answer your question. Cynthia, this is a great question, and we talk a lot about this topic. For ladies over 40, how many embryos max do you transfer? Typically, it depends. That it's dependent on the age of the embryo and your age. I would say typically, I'm thinking of the guidelines off the top of my head, but I do believe over at 40 or over, transferring two would always be within the realm of appropriateness or within the guidelines. I believe that day 3 embryos, I think at 40 you could transfer 3, but this all, it has to do with the clinical appropriateness in your specific situation. Are you able to use comparable medications from Mexico? You're permitted to use whatever medications you choose. We do not recommend procuring medications from outside the country, just given that there are far less regulations that determine that those medications are what they say they are, that they are going to have the effect that we're expecting. And so as a general rule, we definitely discourage the use of medications from outside the country. Let's see here. So I come in June 3rd for consultation. I have my tubes tied for 12 years now. I'm 31 years old, and I was wondering if IUI is best, or if, I'm guessing you're asking IUI versus IVF. In your situation, you would need to do IVF, given that if your tubes are tied, your eggs would have no way to get from your ovaries to your uterus because there's no tube that would allow them to make that trip. So unless you were to look at a tubal reversal, which you could certainly speak with our office about, IVF would be the only option in a situation of a tubal reversal. So I hope that helps. Let's see here. This is a good question, and one that I come across a fair amount. How long after fibroids being removed can you do a transfer? That's really up to the severity of fibroids, how involved the myomectomy or the removal of the fibroids was, and your individual body. If the myomectomy is, and it's going to matter too if it's done laparoscopically versus an open myomectomy. So that's really kind of an individualized answer depending on the extent of the fibroids, the location of the fibroids, and how the fibroids have to be removed. Let's see here. Felicia is asking, my AMH increased from low to normal. That's fantastic. Since your protocol was given starting this cycle, will nurses readjust dosages based on that? It's certainly worth discussing. I would send a message to the patient portal just to have a provider review that and decide if, just given, I don't know what your age is and how much it increased. So there's certainly a chance that dosages may need to be decreased, or it might look, if it's close, it might look like, maybe we ought to start with that initial dosage that was given or that initial protocol. All right, what else do we have? Vanessa is asking, I have to make an appointment with my doctor, but they don't know what an SIS test is. Well, if they don't know what the test is, then you probably need to find another provider who does. I don't know who you asked, but SIS stands for saline infused sonogram. Unfortunately, that test goes by a lot of different names. So sometimes it's called a saline sonogram. Sometimes it's called a sonohistogram. Sometimes it's called a saline sonohistogram. So there's lots of different names for it. It is a process where we infuse saline into the uterus to evaluate the contour of the uterus to make sure that there are not filling defects or things like polyps or fibroids that would negatively impact an embryo's ability to implant in the uterus. And so I would say if they're not familiar and it was your OB that you checked with, maybe try using the terms sonohistogram or saline sonogram. If they're still unfamiliar, I would suggest perhaps checking with an outpatient radiology clinic in your area, or potentially just contacting your PCP to see if they might know somebody who does the test. Alternatively, you could always have that test done in our office if worse came to worse. All right, let's see here. Alexandra, you're going to make my face hide because this is a long question, but basically appointment with the Atlanta office on the 11th, all your tests are done. How soon can you start medication? Typically, like I mentioned before, it's going to be 3 to 4 weeks from your consultation on the 11th before you receive an orientation call from our staff. And then with the first period after that orientation call, once you have all of your medications, you can get started. In terms of monitoring, that's a very good question. And it really depends on the options in your area. So if you can travel to the Atlanta office for all of your monitoring, my guess is that that's going to be less expensive, but you would need to inquire in your area to see what ultrasounds may or may not be covered by insurance in order to essentially determine what option would be less expensive. But I would recommend once you have your consultation, our financial team will reach out and they'll be able to help you at least understand what monitoring here would be. And then you could call around and kind of compare into what, your local offices offer. Alyssa is saying, for those of us traveling, will we have to find a local clinic for monitoring before doing an FET? Yes, unless you would like to come to one of our offices for everything. Most of our travel clients do have a local office that performs their ultrasound and lab monitoring leading up into their procedure. So short answer is yes, but you could certainly come to our offices for all monitoring if you would like to. So that should be kind of work either way. All right, let's see here. So this is such a good question, Kellyanne. I'm so glad you asked it. I've had 2 children prior to cutting my tubes, and my husband and I are doing IVF. What I still need to be on is much medication. So the amount of medication that is recommended by the provider during your consult is not related to whether or not you have your tubes tied. So the protocols are determined based on age and based on some factors that indicate what your ovarian reserve is. And so I would say, if you've had 2 children naturally prior to your tubal, there's a great chance that we might be able to use less medications, but that would really come down to kind of what your individual numbers are with regard to your ovarian reserve. Charity, Atlanta does do saline sonograms. I do not know the cost. Unfortunately, I will never be able to answer a cost question on this feed. So they do perform saline sonograms. Just double check with our financial team to see what that cost would be. Let's see. Oh, depending on the size and number of scars on your uterus, can be 4 months up to a year. For some doctors, mine said 6 months. Okay, so I think this was maybe a potential answer to the question about fibroids, so I'm going to leave that go. Okay. Casey is asking, I can't seem to find the immune protocols on the site. Who decides what protocol I do? And stage 3-4 endometriosis with only 1 ovary. So the protocol is going to be determined by whatever provider does your consultation. So that is going to definitely take into consideration that you do only have 1 ovary, because we know that since we don't have both ovaries to work with, we may need to stimulate the existing ovary a little bit harder. As for the immune issues, it's certainly going to be up to the provider to decide based on your specific immune issues, what treatments may or may not be suitable. I would say on our website, I know that the immune information is there. I'm just trying to locate quickly where it is. I think it could be under the Fertility 101 tab on the website. I'm not locating it quickly at the moment, but check under the tab that says resources and Fertility 101. And then you could also look under the fertility treatments tab, and I hope you could find it under one of those. If you can't, send a message to the patient portal and we can certainly look it up at that point and give you the exact link to it. But all the immune protocols are on they are on the website, and which protocol is appropriate for you would be determined by the provider based on your history. Sylvana, no, I am not a doctor. I'm a nurse. Somebody answered for me. All right, Janelyn. Man, just had my 2nd chemical. My embryos are implanting, but I get very poor betas every 30. Janelyn, I really would highly, highly recommend a follow-up talk because typically when we're having embryos that implant, but we get poor betas and the ones that end in chemicals, there's a good chance that we may need to look into one of two things, if not both. One is oftentimes with repeat failed implantation or chemical pregnancy, sometimes we want to look around in the uterine cavity or in the pelvic cavity itself for the presence of things like endometriosis, adhesions, tubal issues, things that might be secreting inflammatory markers that are then going to be toxic to the pregnancy. So laparoscopy, hysteroscopy is an often recommendation for this type of scenario. And then another thing that we could take a look at would be some recurrent pregnancy loss testing if you haven't done that already. Things like antiphospholipid antibodies, anticardiolipin antibodies, lupus, anticoagulant antibodies. There's a lot of different inflammatory markers and immune markers that if we can find them to be elevated, we can target that specific abnormality, if you will, with things like blood thinners or Neupogen. So we have a lot of the immune protocols. And kind of going back to the last question about, well, who decides and how is it decided? Sometimes the RPL labs, the recurrent pregnancy loss panels, can kind of help streamline what specific or what specific immune protocol medications might be appropriate for you. But this is extremely frustrating, and I'm so sorry because I can only imagine this throwing your hands up in the air sort of that you get the positive, but then it doesn't continue on. So I am so sorry, but I know that you are like many of our other clients that we are eventually able to determine what we need to do to get you to the finish line. So please do not give up hope. There is an answer for you. And I think if you just had your second chemical, if you've not had a follow-up talk yet, I highly recommend, and our nurse practitioner, Grace Michelle, is an absolute genius with regard to immune issues. And so I would highly recommend any of our providers would be fantastic, but specifically for that issue, I would see if you can get a follow-up talk scheduled with Grace. All right. Devin, when do we graduate? I had a positive beta today of 154. Devin, that's amazing. I'm so happy to hear that. I know we have to do one more beta and a sonogram. So that's right. So what we typically do is with that positive beta, we'll send you back 2 days later, confirm that we see that appropriate rise, 66% over 48 hours. As long as that looks good, we usually send you for your first ultrasound 1 week later. Now, if 1 week later, we've got a beautiful heartbeat, an appropriately sized gestational sac with a yolk sac and a fetal pole that looks and measures appropriately, at that point, oftentimes you're going to be able to graduate at that point. Every now and then, if there's something that we want to watch just a little bit more closely, we'll tell you, go ahead and get an appointment with your OB. But in the meantime, we want you to go back one more time just to make sure that everything is looking good. So congratulations. That is an amazing, amazing, amazing beta today. So let's be fingers crossed and toes crossed that that's looking amazing on Wednesday. All right, let's answer some more questions. Hi, Becca. Let's see here. Sorry. Okay, this is a fantastic question, Leslie. In what situations do you use only Lupron for trigger instead of HCG? So there is a sort of algorithm, for lack of a better word, that we use to determine if you're going to use only Lupron, only HCG, or a combination of both. And that has to do with quite a few different factors. Your age, your AMH, the number of follicles that we expect you to have mature at retrieval, and your estrogen levels. And all four of those pieces of information are sort of analyzed to determine which combination of trigger is going to be best for you. So as a pretty general rule, if you are older with a lower AMH, less mature follicles, and a reasonable, I would say, estrogen level, you're probably going to get one of each. You're probably going to get one Lupron and 10,000 units of HCG. We decrease the amount of HCG provided for trigger as estrogen increases, given that the HCG does act sort of to flare the ovaries after retrieval. So if you're at a high risk for ovarian hyperstimulation syndrome, which is where your ovaries are so overstimulated that after the retrieval, usually 4 to 5 days after the retrieval, there's a fluid buildup in places that you're not supposed to have extra fluid. So in your pelvic cavity, it can press up against your peritoneum. It can make it hard to breathe. It can make it hard to urinate. That's a situation where if we think you're at high risk for that, you're going to get much less HCG, if any HCG, because we just want to protect you. Only Lupron, that would be a situation where estrogen's pretty darn high. Usually above 3,000 is going to most likely be a Lupron only trigger. And then there's other parameters, of course, that are kind of individualized based on your own unique situation. But I hope that kind of gives you a general kind of idea how we choose to trigger. So, and with that, a word of caution, I see a lot of questions that come through the patient portal that say, I saw so-and-so triggered with this and this. Am I supposed to do the same? And so I think it's super important to keep in mind that these are individualized decisions based on all 4 of those parameters that I mentioned. And so unless you are the exact same age with the same AMH, the same number of mature follicles, and the same estrogen level, don't be surprised if your trigger is different. It really is truly individualized. This is a great question from Viviana. She says, does PRP and HCG wash help with implantation? Yes, 100%. So HCG's presence in the uterus helps to prepare the body for an environment where there is HCG, for example, a pregnancy. And so it helps to improve implantation rates. PRP helps to increase growth factors and the overall receptivity of the uterus so that it can engulf the embryo and begin that process of implantation and early fetal development. So 100%, I'm a huge fan, proponent, recommender of both PRP and HCG wash. All right, let's see here. Bear with me here. The comment section is a little bit hard to follow. Let's see here. So can you get OHSS with HCG boosters? Probably not. It's such a small amount. Technically, I don't know. I suppose if you're very borderline, that could throw you over the edge. But as a general rule, we're probably not going to instruct you to do HCG boosters unless we feel that that's not a risk. So next question, from Nicole, would you suggest transferring 2 different graded embryos? I only have 2 frozen left after a retrieval and failed transfer of my 2 good graded embryos. I'm so sorry. This will be my first FET after a chemical and a failed transfer, and you've 36, been trying for 12 years. God bless you, Nicole. You have been through so much more than any one person should ever have to endure with this process. So my heart is with you. In terms of 2 different graded embryos, this is a very good question for the embryologists. I would say there are arguments on both sides, but I believe our general consensus is that no, each embryo has its own individual chance of implantation. So, but for further information, I would recommend checking in with the embryology team just to make sure that for your specific scenario with your specific grades of embryos, that what I'm saying is just generalized. So I hope that helps. Lee, yes, you can absolutely do HCG and PRP wash, and most people do. And they're both done in the same procedure. The HCG is typically added to your PRP and then infused into the uterus at the same time. So that's a great idea. Amy says, you're so helpful. I appreciate these lives. Thank you, Amy. Is it typical to not hear or see a heartbeat at your first ultrasound after positive around 5 weeks, 6 days? Yes. It is 100% normal to not necessarily see a fetal heartbeat at the first ultrasound. So the fetal heart rate starts somewhere between, I've seen it as early as 5 weeks, like 3-4 days, all the way up to mid 6 weeks, 6 weeks to 3 days. So yes, at 5 weeks, 6 days, I would not worry yourself at all. As long as betas are rising appropriately, I would say that's 100% normal and expected in terms of maybe not seeing the heartbeat at that point. All right, what else do we have? Can you clarify the timing of PRP with a fresh transfer? I thought you said it could be done at retrieval, but my message came back to say, okay, so the PRP that's done at retrieval, I believe you could do a PRP to improve your lining at retrieval. The lining or the PRP treatment that helps best with implantation enhancement is typically done 24 to 48 hours before the transfer itself. So since retrieval is kind of outside that window, I suppose you could go either way. A lot of the PRP that's done at retrieval, not necessarily a lot, but some of the PRP that's done at retrieval is ovarian PRP, where your plasma is injected directly into the ovaries in an attempt in a future retrieval to help improve your ovarian outcomes. But with that said, you certainly could do a PRP wash, if you will, at your retrieval. They couldn't tell me if it was appropriate until after retrieval. I think you could really go either way. Most often the PRP for implantation enhancement, though, is done 48 hours beforehand. So that's probably what I would go with. Let's see here. We have about time for probably 3 or 4 more questions. So let's look here. This is a very, very good and very common question that Micah asks. Do you help find monitoring locations if we are not close? I wish we did and could, but we do not necessarily. You can always ask in the patient portal if one of the nurses happens to know of a place. We do have an affiliate monitoring map on the cnyfertility.com website under the travel tab. That might be a good place to start. And to see if any of those locations are near enough to you. But truly what we have most of our clients do, just start with your OBGYN. It's very helpful to make a preconception visit appointment with your OBGYN, especially if you have not seen that provider in a while, just to let them know you are pursuing this. You're going to need their help as soon as you're pregnant. So having your OB do the monitoring, if possible, is really best case scenario, because when we say, well, we're discharging you to your OB for care, your OB has really been involved in that care from the beginning. And so wherever and whenever possible, I really believe that no one should go through IVF unless they already have an established OBGYN, because I cannot tell you the number of times that a situation crops up that requires a local provider to evaluate it. As amazing as we are doing telehealth. And so there are going to be times where we say you really need to go into your OB and be seen, and it complicates things and kind of slows the process down if you do not have an OBGYN. So while we don't necessarily, we can't necessarily find it for you, definitely check our affiliate monitoring map. And then if there's nothing nearby your location, I would say call local OBs and get established with one and see if they're able to do the monitoring. And then a follow-up question to that from Micah as well is, if the transfer is successful, do we continue early pregnancy monitoring with us? And that's going to be the same answer to someone was asking kind of a while up, when do we get discharged? And as long as we have your first beta, your second beta is appropriate in terms of its percentage rise from your first one, then a week ultrasound, we see all the things we're looking for. So we see a gestational sac in the uterus with a fetal pole, or with a yolk sac, a fetal pole, and a heartbeat. If we see all of those things at the first OB ultrasound, we're probably going to say, okay, off you go to your OB. But there are cases where, folks, want to stay with us for a little bit longer, and we do that where possible. But usually once everything looks great, you're off to your OB, because that is your local provider, and they are the best suited to monitor you and handle anything that might arise. Felicia, this is a great question, and a good topic to talk about. I will be monitoring locally, nervous about getting results to you in time. What happens if they come later than 2:30? So what happens is that we will do our very best with the information we can get. The reason we ask for them by 2:30 is because we monitor hundreds of patients a day. And so if we don't get, it's okay if once in a while your results come in at 3 or 3:30. But if think about if everybody's results all came in at 4:30 p.m., we're going to have a very hard time having those results reviewed, developing a plan, and calling you and communicating that plan to you. And so we will always do the best we can with whatever information we can get. If you have the feeling that your monitoring center might have difficulty, and we know that our clients that are on, the more Western time zones, we know this can be difficult. I always recommend find a friend at your local monitoring facility, an office manager, a nurse that you get along with, a tech that you get along with. Explain to them, get some buy-in from them, help them understand how important this is, what you're doing, and why it's important that we get the results on time. I find if you can build a relationship with somebody, then they're invested in seeing that we get the results on time and things like that. So the short answer to your question is we will always do the best we can with whatever we get. But obviously, if your stimulation day 10 today, and we need to make a trigger decision on you, if we don't get those results by the time we leave, then we're not going to be able to necessarily make the best decision for the best possible outcome. So, we always will, though, do the very best we can with what we get. All right. One final question. Let's see here. Actually, maybe you guys don't have any more questions. Oh, okay. Here's a good one. From Jessica, can you discuss day 3 versus day 5 embryos? What determines if you freeze day 3 versus day 5? So first of all, it's your choice. First and foremost, if you have had previous IVF cycles where all of your embryos have arrested between day 3 and day 5, and you have a strong feeling that you want them to be frozen on day 3, great. Or if you say, you know what, no, day 5 embryos always have a higher implantation rate and a lower miscarriage rate, I only want my embryos to go to day 5, then day 5 it is. But if you are relying on us and our expertise, our kind of process for that is if you have 4 or more good quality embryos on day 3, we're going to move those into what we call extended culture to day 5. So we're going to continue watching them, growing them, and see what's there on day 5. It's normal to have attrition between day 3 and day 5. So we know that not all eggs will be mature. Not all mature eggs will fertilize. Not all fertilized eggs will make it to day 3. And not all day 3s will make it to day 5. And this is just the natural process of sort of identifying that embryo that has the best chance of making it into a good quality ongoing pregnancy and a live birth. So what determines it is primarily the number of embryos that you have that are good quality on day 3. If you have 4 or less, we're highly going to recommend that you transfer or freeze those then, versus if there are more than 4 and things look good, then we're going to grow them out to day 5 and either transfer one on day 5 and freeze or what have you. So I hope that answered your question. It's a tough one, but we try to do what's in each individual client's best interest with their embryos, their unique situation. And so there's always kind of gray areas, but we do try wherever possible to involve you in that. As I always say, they're your embryos. It's your time, your embryos, your money. So Dariana, I know I said the last one was the last question, but you seem to be very interested in the answer to this question. And your question is, what do they do if they find a scar tissue? So it really depends on where the scar tissue is and what that scar tissue is doing. So if you've got scar tissue on the outside of the uterus and it's adhesing or sticking your tube to your uterus and causing problems, then we're probably going to recommend that you go in for a laparoscopy and have that addressed. If the scar tissue is in the uterus itself, just depends on what that scar tissue is. If it's from a C-section, then it might not need anything addressed. If it's other types of scar tissue, it really just depends on what it is and what we think the potential outcomes are based on that scar tissue in that location with your specific situation. Okay. Somebody was asking, there's a whole bunch more questions I didn't get to. Vitamin D is super, 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 super important. If it's too low, how long before an FET should you start taking vitamin D? It depends on what your level is, but I think everybody everywhere needs to be supplementing with vitamin D. As a general rule, we don't get enough in our nutrition and from the sun. So highly recommended to start that process now. We can draw a vitamin D level on you anytime. It's always good to have a starting point to know, obviously, if your vitamin D is at 50 right now, we're not going to have you supplement with as much as somebody who's okay. So yours is 17. So most of the time we are supplementing with about 5,000 units a day and retesting in about 6 weeks. And so vitamin D is very important to the process. So, okay. Is going to be it and wrap it up for us. I am sorry if I did not get to your specific question. I apologize. You are more than welcome to send that message as a question through your patient portal. If you are a travel client, always direct those questions to Global Travel Questions. There is the temptation to send those questions directly to the office where you'll be having your procedure. But as travel clients, our team will handle everything for you up until the point that you step foot in one of our offices. So if I did not get to your question, feel free to send us a message through the patient portal. Next week, unless the plan changes, next week I'll be having Nurse Linda on for our Medication Monday. We're going to talk all about each individual medications that are used for IVF, FET, IUI, what they do, how they work, what their side effects are, and all of the above. So that's going to be hopefully next week. And then if you guys have any suggestions for future topics, definitely let me know what those are. But I certainly do hope that the hour that we've spent together has been helpful. And I wish you all the very best in whatever part of the journey you are in, whether you're in the beginning or the middle, whether you're frustrated that things are not working out the way that you hoped. Keep the faith, keep going, don't give up. You can do this, and we're here to help. I hope everyone has a good night. See you later.